Okay, everybody. Hello. Welcome to the final video lecture of this course. I am going to use this lecture as a way to sort of sum up most of the stuff that we've done in this course. I will tell you, I expect this lecture is going to be considerably shorter than an hour. The reason for this, and I'll explain this towards the end, is I decided that I was going to include a couple articles. I did not, that was not in the syllabus, I realized. But so, in order to give you time to review those articles, I'm probably going to shorten the lecture and then include the articles. The reason that I'm doing that is that this lecture, sort of as like a way to finish off strong here, is going to talk about using the techniques, the quantitative research methodologies that we've talked about throughout this course to move on um, as far as understanding and also planning for your own clinical research and finding where that is. Now, what I am going to use at least a part of this lecture, a good part of this lecture on, is talking about resiliency. And you'll notice that in the syllabus. The reason that I'm going to talk about that is resiliency and resilience is probably the biggest concept being studied in any sort of clinical counseling, whatever research. If there is a buzzword in clinical psychology research, it is resiliency. If there is a buzzword in what insurance companies are looking for to prove whether a treatment is valid or not, it's resiliency. The bottom line of what resiliency is and why it is so important in clinical, and the two are connected, by the way. One of the reasons it's such a um, big factor in clinical research, and by the way, I'll just use the term clinical research for meaning any sort of um, you know any sort of psychology research, including healthcare psychology, medical psychology, behavioral medicine, sort of the category of subjects that sort of cross over between medicine and psychology, um, medicine and behaviors. Um, all of those areas, insurance providers, third care party providers, anybody who is paying for or is responsible for treatment is looking for evidence that the treatment methodology that is being used has resiliency. And I will talk about it in detail, but at the very bottom level, in terms of summation, resiliency is basically the degree to which a treatment has lasting effects. So you may treat someone for depression, um, do a case study on someone you're seeing for depression. You see them uh, 2 months later, they're they maintain the progress. So you see them, you do testing, you find out at the end of testing or at the end of treatment, their depression is better. They're not depressed. You give them a Beck depression inventory, they don't score in the clinical range. 2 months later, you contact them again. Maybe it's an agreement you have so that they can be part of your case study or whatever research you're doing. 2 months later, you see them. Um, uh, they're still better. But what you don't know is, do they maintain those gains for 1 year, 2 year, 3 years, whatever down the road? And this is why the term resiliency is coming to use, because resiliency adds also the concept of not only length of time, not only that they get better over time, but um, that they that they maintain the progress when facing other stressors. So, for instance, you know, resilience probably came into play as far as an important concept in the clinical literature with substance abuse, alcohol abuse, say. Because what the question was that no, probably more for something like heroin uh, abuse, opiate addiction, because the rise in the importance of resiliency as a concept sort of coincided with the rise in opioid addiction becoming more and more of an issue. Um, and the question that was asked was this: um, yes, this person is no longer using heroin on a regular basis. Yes, they have gone 3, maybe 6 months without using heroin or pain pills or whatever. But what happens the next time something stressful happens in their life? Um, because maybe 6 months have gone by and nothing big has changed uh, in their life. And they haven't undergone the stresses. They haven't lost a spouse. Um, they haven't lost a job. They haven't had to um, deal with the, they haven't had to deal with a family crisis, even something positive. You know, one research result that I often refer to in clinical work is, you know, they've done studies on the top stressors in people's lives, and top of the list is getting married and having children, which are positive things for most people, but still have a high amount of stress associated with them. So the idea is that um, resilience is that degree to which the person not only maintains progress that they gain from clinical treatment, but that progress keeps going even when they're facing other stressors. And in fact, one reason why resilience also became much more of a concern, much more of an issue with the rise in opioid addiction was because much of the problems with opioid addiction um, started with people who got into opioids, became addicted to opioids because of pain medication. And resilience came as an issue of, okay, you've got this person dealing with everything better, but what happens when their pain gets worse? Is this person just going to go right back to pain medications, which means, you know, they've now opened the door to getting back onto opiates? So that was a major concern was, well, what happens when this person has to deal with the stress of being in pain again? What then? What goes on then? And so um and so that was the issue of, well, what happens when uh when the stressors are have increased again? And what I want to do here, I know I'm talking about a clinical issue. What I want to use as sort of a way of wrapping up is I'm going to talk about resilience, but I'm also going to talk about what research has shown. And the articles that I'm going to have you read that I will put online tonight or tomorrow morning relate to, um, there are articles that show how resilience is being studied. I will talk about that here and how it's gone. So basically, I am ending this course with a discussion of how the most prominent uh, issue in clinical research, resiliency, how exactly the quantitative methods we have talked about throughout this course are being used in order to study it. What have they found already? And what is what is out there. Because if you think about it too, from a quantitative point of view, it's a little bit complex because you can't just you can't just measure progress over time. You've got to measure progress as it runs face to face with um, challenges and the person facing challenges in their life later on. Um, and so when I was in when I was in graduate school, the school that I went to, so I had a public education campaign on psychology, not just not just mental health, but specifically psychologists. And their phrase was psychologists helping people help themselves. Many psychologists and also generally psychotherapists will tell their clients, tell their patients, um, my job is to get it to the point where you don't need me anymore. That's both of those are a reflection of resilience. That the idea being that clinical interventions are supposed to a person not only deal with challenges that they have now, but develop the skills so that they can get through challenges when they face them later on. By the way, interesting side note, this has changed in recent years. When I was in graduate school years ago, and up until maybe I don't know how many years ago, but for a while, that was seen as the biggest difference between clinical psychology and counseling psychology. Counseling psychology was seen more as coping skills to help you deal with what's going now. Clinical psychology was seen as making sort of more permanent changes that let you meet with challenges regardless of where they are. Now, what was kind of recognized, and that's why, for instance, counseling psychology programs are still mostly in education programs. Um, for instance, I do dissertation committee work for dissertations for individuals who are working to their counseling psychology PhD. The doctorates they get are actually not PhDs, they're EDDs, which is Doctorate of Education. Counseling is still um, uh, uh, taught. Counseling psychology programs are still primarily associated with education departments, um, whereas clinical psychology are usually in the psychology department. That was often seen as the difference. Counseling was seen as more you educate the person on coping skills to help them deal with what they're doing now. Now that may or may not help them if they face similar challenges in the future. It's just the degree to which those skills generalize, there's that term again, generalize to those other situations. Clinical psychology is focused more on the sort of long term ability to deal with challenges, regardless of what challenges the person faces. That line has become blurred, certainly over the past decade or so. But it is an explanation of why counseling psychology is often associated with education departments at universities. Okay, so what I'm going to do with those articles is I'm going to uh, find articles for you that are really good examples of how resiliency is studied. I have a couple in mind, but I got to decide which ones are the best examples. So I'll have that on. I'll post those online. You watch this lecture first, and you'll have those articles later. Because I figured I could, and I will talk about how resiliency is studied, but I thought it might be better to actually have you see them. Okay, so what is resilience? Resiliency is the ability to bounce back, the ability to take on difficult challenges and still find meaning in life, respond positively to difficult situations, rise above adversity, cope when things look bleak, tap into hope, transform unfavorable situations into wisdom, insight, and compassion, and endure. Those are some of the aspects of resilience. By the way, um, notice how that one transform unfavorable situations into wisdom, insight, and compassion. What's the old saying? That which that which does not kill you, only makes you stronger. It's sort of along those same lines, that same line of thinking that, when you get through adversity, sometimes the most important thing is to um, figure out what you can learn from it. Um, and it's definitely determined uh, to become more of a process um, of rather than like a one-time thing. It's a process rather than a trait of the individuals. Now, what has research shown to be important ways of building resilience? What is the quantitative research shown about the ability about what helps with the ability to build resilience? And there are 10 ways that have been identified um, through research done by the American Psychological Association. Um, One is to maintain close relationships with family, friends, and other people. Um, Avoid seeing crises as unbearable problems. They're situations, not unbearable problems. Accept circumstances that cannot be changed. Develop realistic goals and move towards them. By the way, notice that one, to accept circumstances that cannot be changed. Notice how that's in line with um, the Serenity Prayer. If you've ever known anybody in Alcoholics Anonymous or Narcotics Anonymous or Gamblers Anonymous, the Serenity Prayer, as I forget exactly how it goes, but something like, God grant me the strength to recognize the things I can change, accept the things I can't, and the wisdom to know the difference. Same concept there. To accept circumstances that can be not changed, to develop realistic goals and move towards them, to take next way of developing resiliency, take decisive action in adverse situations. Next one, look for opportunities of self discovery after a struggle or a loss. Next one, develop self confidence. Next one, keep a long term perspective and consider the stressful event in a broader context. Next one, maintain a hopeful outlook. Where you try to expect that good things can happen. The next one is exercising regularly and taking care of your physical health as well as your emotional health. So those are 10 things that resiliency has that research has shown to be uh, uh, that research has shown to be important ways of developing resiliency. What I want to do now is talk about um, what, like generally how a study of resiliency would go. Like I said, I will give you articles and some, and basically why I'm summarizing this is I don't have one article that encompasses all the items at once, but there are measures of um, resilience that are out there. And um, okay, so there are a number of resilience scales out there. So I want to walk you through sort of the process and notice how I'm following along the steps we've talked about throughout this course. So the first thing you do is you find a measurement. You find uh, uh, there have been a number of resiliency measurements out there. Actually, one that's been found that contains quite a good amount. Remember the terms validity and reliability. So you find a scale that has good reliability and strong validity. And one of the ones that's been found as a resilience scale to actually be to have both those psychometric properties pretty strongly is called the brief resilience scale. I want to take a side note here as I talk about the brief resilience scale to talk about an issue. This is a specific example of something I've talked about throughout the course, which is very often what you're looking for when you develop a test for a construct that's already measured elsewhere is to find a test to basically figure out how short you can get the test. Can you get it down to just, if there's 21 items, can you get it down to 18 items? If there are 18 items, can you get it down to 12 and still have the same degree of validity and reliability? Oftentimes, when there are a lot of instruments out there that have the word brief in front of them. When I was consulting to um, medical facilities more often than I do now, a lot of people I saw were over 65. And so there was a scale called the geriatric depression scale. I did not even realize, I used it for about 2 years before I realized that the geriatric depression scale I used, which was 15 items, actually said on it brief version. I had never seen that. It was one everybody was using, but it had 15 items and the original had 30. Um, so very often, what you will do, as I talked about several classes ago, I talked about how there are changes in tests. And sometimes it's because it's a better quality. Sometimes it's because it's a different method. I talked about the Beck Depression Inventory and the Hamilton Depression Scale. The Beck Depression Inventory is um, a self-report measure. You ask the person questions and they mark it off. The Hamilton is a rating scale. The provider rates the individuals on certain symptomology. Um, so that's one. Um, but very often, one other change will be a shorter version, and very often the individuals doing the test on the shorter version will um, be the people who developed the test in the first place. Um, and um, that's what happened with this scale. So the scale that there was something called the resilience scale, and now there is a scale called the brief resilience scale. And what I like about this and why I think this is a good example of what I just spent a couple minutes talking about is it's only 6 items long. So it has a good degree of validity and reliability, um, but it is only 6 items, where I believe the original was like 20 something items. So it's a good measure for it's particularly good measure, and making for a shorter instrument is particularly good for quantitative research, because a lot of times, remember, we've talked about this a number of times in the course, a lot of times the practical issue that you have to consider is how much of people's time are you taking when you develop it? How long, if you ask them to agree to be part of your study, how much of their time are you asking to take? And so 20 items might take 15 minutes, 6 items might take 5 minutes. So you're cutting to a third the amount of time that you need to take for someone. Um, One other note, too, about this brief resilience scale, I have pulled up some material that I have on this scale, and I just pulled it up from an article about the brief resilience scale. But what's interesting is the article itself. I pulled up the material because I like the summation here, but the article itself is called "Validation of the Polish Version of the Brief Resilience Scale." So essentially, what this is a scale um, that was developed in English, and they translated it into Polish, and now they have to decide if there's reliability and validity for this Polish version. Uh, so that's another reason that you'll see multiple validity and reliability tests for an instrument is if it's written in a different language or it's being translated to a different language than how it was initially validated. Okay, so the brief resilience scale has 6 items that are rated on that Likert scale. 5 points from 1 being strongly disagree with the statement to 5 meaning strongly agree. And it's basically asking the person if they see themselves having the different aspects of resiliency. Okay, so you get a strong instrument uh, like the brief resilience scale, and then you uh, the instrument the testing for resilience often has to be multi-level. So you have some studies that are time series. So you give the brief resilience scale um, after certain types of treatment, um, uh, you know, at 2 months, at 6 months, at a year, and 2 years. So it's time series. You test the level of resilience over time. And then the other um, way of measuring, the other way of deciding what the factors are that contribute to resilience is you determine what the person has in their lives. Have there been uh, have there been major events? How are they approaching life? So there's 2 levels of research on resiliency. One is just over time, So, and what I mean by over time is you test certain treatments. So somebody maybe gets cognitive behavior therapy, another one gets psychoanalysis, another just uses a workbook, and then you see time series um, over time if any of them come across as having a stronger impact, if the degree to which um, the time series changes. And then also, the other way that time series, remember I talked before about time series, is um, sometimes that measure of um, the time series can measure when certain events happen. So you may get things over time, and like when you reassess them in 3 months, 6 months, a year, 2 years, you ask them, have any of these events occurred since the last time you were assessed? So it could be a time series where you also are gathering information about specific events that have occurred. The other way that resilience can be studied is not individuals who go through treatment and then you study them following treatment, but it could be finding individuals who have gone through treatment. And so you ask them, were you in therapy? Do you have a history of being in therapy? Uh, or otherwise find individuals who had been in therapy before and you find out what sort of therapy they got. Or you just find out from individuals certain aspects of their personality and see what um, what factors correlate the strongest with um, resilience. So um, it could be a correlation design, studying this one personality characteristic and associating it with resilience. And it could also be an ANOVA where you have um, groups of individuals, some who, for instance, are able to, um, who have strong emotion regulation skills. So you test the individuals to see if they have strong emotion regulation skills, and another group that has weak emotion regulation skills. And you do an ANOVA or a T test um, to see if there's any difference between those two groups on level of resiliency. And maybe on the same test, you also measure things like optimism and see. So There's a time series that you can do with resilience. There's the correlation studies that you can do, regression analysis, which is, like I've said before, sort of an advanced type of correlation study. So there's regression analysis that you can use with resiliency um, being the predicted value variable and the predictor variables being these other personality characteristics and possibly the type of therapy that the person was in. You could do t-tests and ANOVAs where you test group individuals split into groups based on different personality characteristics, whether they are high or low in those areas. Um, and those are some major, those are all ways that resilience has been studied. So as we come to the end of this course, um, this is probably, like I said, the most prominent um, construct that you will find in the clinical research is this idea of resilience. And the conclusions that have been drawn about resilience um, are all based on combinations of those types of research. And just to let you know, some of the factors that have been found to be associated with developing resilience include having a positive attitude, optimism, good emotion regulation skills, and the ability to see failure as an opportunity. Other factors, um, caring and supportive relationships, um, the capacity to make realistic plans. So you kind of want to see that as an issue that maybe you want to sort of focus in on uh, for therapy. You know, that those are some aspects of resilience that can be targeted in therapy. And it's one of the reasons why resilience research is so important because it helps to identify not only what sorts of therapy are most effective for promoting resilience, but also what aspects of therapy are important. And one of the things I wanted to get back to is if you look at the things I outlined there, and this will be the last point, and then I'll wrap everything up here. If you look at everything I outlined there as far as factors that contribute to resilience and different ways of building resilience, notice if you put that together as a list, you can see what sorts of things need to be targeted in clinical interventions for helping to build resilience. And it moves you away from uh, an issue that is studied less in clinical research, which is what type of therapy, cognitive behavior therapy, psychodynamic therapy, humanistic therapy, behavior therapy, moves you away from that and moves you towards what are the common factors that impact clinical uh, effectiveness. And in fact, there's a movement. Common factors was what it had been called. There now is a uh, sort of another term that's come about called meta psychotherapy, which is the idea that there is an approach to psychotherapy that isn't named anything, like it isn't a specific school, but is a way of using what research, putting together all these common factors that that make for effective therapy. So I guess that's where I wanted to end. That clinical, what you want to be prepared for as you look into the clinical research is much of the time the research is not on uh, what specific school of thought has the most impact, but what specific factors tend to have an impact. And when they study, when there's clinical research on types of therapists, regardless, what kind of has been the general conclusion is it almost doesn't matter what school of thought they say they practice. As long as they have these common factors, they tend to be more effective. Okay, like I said, I'll end that there and I'll post copies of the articles that I want you to look at that are good examples of resilience research. And then we'll pick this up when we meet on Thursday.